So in this chapter, 26, we're going to talk about acute kidney injury and chronic kidney disease. So when the kidneys fail, ultimately less waste is removed because we know one of the functions of your kidneys is to remove excess wastes. So these wastes actually accumulate within blood. And what we'll see are things like nitrogenous compounds that accumulate, things like blood, urea, nitrogen, and creatinine. If these are more elevated, that suggests that the kidneys are failing to remove these wastes. Now it gives you more of an approximation of renal function, and the way we can determine whether the kidneys are clearing out, a particular amount of waste is we just need to compare things like initial versus current levels of these wastes, like initial creatinine versus current creatinine, and that'll tell you if your kidneys aren't able to clear out that waste appropriately. So we know that some other functions of the kidneys are to regulate things like fluid, electrolyte, and pH balance. So that if your kidneys are failing, you get fluid accumulation, which can lead to things like hypertension. We see electrolyte imbalances with kidney failure as well, like through the accumulation of sodium and potassium and other ions. And then pH imbalances can result because we know that the kidneys are the third line of defense, and they're going to be involved with getting rid of things like metabolic acids, but also helping to regulate blood pH long term. So that if the kidneys are failing, you can see things like pH imbalances, whether it's acidosis or alkalosis. Now, how do we differentiate between acute versus chronic renal failure? Well, acute renal failure would be a GFR of less than 15 mils per minute, just sort of an acute or rapid sense. So we're saying that this is going to be on an order of days. Now, chronic renal failure would be a decrease in GFR over the course of 3 months. So in terms of the different ways that the kidneys can become injured, we have pre-renal kidney injury, post-renal kidney injury, and intrinsic kidney injury. And these are all examples of acute kidney injury, or AKI, because if there's an issue in any of these particular regions, it's going to lead to acute injury. So pre-renal acute kidney injury, or AKI, is going to be due to basically a decrease in blood flow to the kidneys, or disturbance in blood flow to the kidneys. Intrinsic AKI is actually going to be damage within the kidney structures itself, like damage to the kidney tissue. And then post-renal AKI can come about from obstructions, whether they're tumors or casts, fibrosis or narrowing of the ureter here, or ultimately just anything that limits the outflow of urine away from the kidney. So with pre-renal AKI, usually the blood supply is decreased, and you're going to see this under conditions like shock. We said that you can get renal injury from severe shock, and this is why you want to assess kidney function if someone survives shock. Extreme dehydration, because less of blood volume decreases blood pressure and you get poor perfusion of the kidneys, or extreme vasoconstriction. And you can find this also with things like shock and dehydration. But with this severe vasoconstriction, this can also limit adequate blood flow to the kidneys. Now, post-renal AKIs, where we're talking about urine flow is blocked. This can come from stones or tumors or enlarged prostate. And when we're talking about stones, we're talking about urolithiases, or basically kidney stones. And all of these can block adequate urine outflow because they are going to either constrict or totally block essentially, aspects of your urinary tract, so that urine's going to back up into the kidney. And we talked about in the previous chapter how that induces something like compartment syndrome, where when urine backs up into the kidney, you get so much pressure that builds up within the kidney itself that it causes avascular necrosis due to inadequate blood flow. Now, intrinsic AKIs, we're saying that kidney tubule functions decreased. This can come about from like ischemia of vessels within the kidney itself. You find this with things like peripheral artery disease. Certain toxins, like there's actually nephrotoxic drugs and other toxins that can affect the kidneys, or intratubular obstructions like urolithiases, like within the kidney tubules itself, can cause intrinsic AKI. Now, acute tubular necrosis is an example of intrinsic AKI, where ultimately there's some form of tubular injury where there's a sloughing of these epithelial cells of the nephron. Now, the problem here is that these tubular epithelial cells form a cast, and these casts can actually block adequate, tubular flow. And so that actually causes fluid to back up towards the, glomerulus, which decreases glomerular filtration rate. And ultimately, due to an increase in pressure, this can also contribute to further ischemia And we can also see that from a loss of epithelial barrier, there's actually going to be fluid that ends up getting forced back into the medullary fluid. We call this back leak. And so one of the markers of acute tubular necrosis are the presence of epithelial casts in the urine. If some of these obstructions break loose and end up in urine, you can find these with urinalysis and microscopy. They just essentially look like aggregations of cells. Now this question here says, which type of acute kidney injury would be most likely to accompany by benign prostatic hyperplasia, or BPH? So BPH is essentially a condition where the prostate enlarges in about 80% of men over the age of 60. And because this affects the urinary tract, would that be pre-renal, post-renal, intrinsic, or extrinsic AKI? Well, we know that would be post-renal, right? Because post-renal would affect the kidneys downstream. And so that post-renal AKI occurs when the flow of urine is blocked by kidney stones, tumors, or enlarged prostate. And because the male urethra passes through the prostate, if it's enlarged, it can impinge on the prostate, which can ultimately occlude the lumen and lead to a decrease in urine outflow. Now this next question here says, a man developed acute kidney injury after emergency surgery for a severed left leg. He came in with a serum creatinine of 1.2, but is now at 5.6 and his BUN's at 86. Now, if you guys remember, normal creatinine levels are between 0.6 and 1.2 milligrams per deciliter, and normal BUN levels are between about 7 to 20. Normal BUN levels are between 7 and 20 milligrams per deciliter. So we're seeing that both his creatinine and his BUN are elevated, which are both indicators of a decrease in renal function. So the question here is, why would leg damage cause renal failure? And what is his remaining kidney function at this point? Well, we know that ultimately some proteins from muscle can make it into bloodstream, or it could be from infection. But we talked about rhabdomyolysis in the last chapter, and how individuals with severe muscle injury can actually end up with excessive amounts of myoglobin in the bloodstream, and that myoglobin can block glomerular filtration membranes, which can decrease GFR and lead to elevated things like creatinine and BUN. And that's one hypothesis here. The second hypothesis could also be that from a severed left leg, he may have lost a lot of blood from that injury and is now in hypovolemic shock, and that due to a decrease in blood flow to the kidneys, you're seeing an accumulation of wastes within the blood itself. Now the question here says, the second one here says, what is his remaining kidney function? And if you guys remember, we said that if your creatinine levels were around 3, then you only had approximately 30% normal kidney function. And so at 5.6 milligrams per deciliter, his GFR is going to be very, very slow. Same with the elevated BUN here. And so remaining kidney function would be about a quarter of normal GFR. So this next scenario says Mr. J is an alcoholic with kidney problems. He is severely dehydrated and also has an infected leg ulcer with benign prostatic hypertrophy and anemia. His urine's dark and contains myoglobin and tubular epithelial cell casts, and his creatinine and BUN are both elevated. And so this question here says, what may have caused his acute tubular necrosis? Well, from all of these, there's a whole wide variety of potential mechanisms here. We know that with alcoholism, that can lead to some pretty severe dehydration, because alcohol is a diuretic, because it inhibits the release of ADH by the posterior pituitary gland, and that severe dehydration can lead to pre-renal AKI, because if you're severely dehydrated, your blood volume is going to be lower, and that's going to lead to a decrease in blood pressure and ultimately perfusion of the kidneys, and that in itself could lead to avascular necrosis of the nephrons, and that can lead to AKI. Now, we can also find some evidence of post-renal AKI here, because he has BPH. And we said that post-renal AKI can lead to a backup of urine into the kidney, which can also cause damage. And we see anemia here, and that anemia might actually be from his kidney injury itself, because anemia can result from the fact that if your kidneys are injured, they stop releasing erythropoietin, so then you stop being able to make new red blood cells. but this would be more of a chronic issue. Like you would need chronic kidney injury in order for it to eventually lead to anemia. Now, his urine's dark and contains myoglobin and tubular cell casts. Now, the fact that his urine has a lot of myoglobin indicates that he has muscle cell injury, because we know that myoglobin is normally found within muscle cells. So if you're finding like a gut component of muscle cells within urine, that's not a good sign. And the fact that he has tubular cell casts also suggests that he has some necrosis of the kidney tubules. Now, myoglobin in the urine may have come about from the fact that he had an infected leg ulcer, and this infected leg ulcer, if it's deep enough and starts to get into muscle, that can end up causing too much myoglobin release into the blood, which can also damage your filtration membranes. But it can also be too just the fact that he has an infection. If it's gone systemic, it may have traveled to the kidneys and also caused further inflammation within the kidneys itself. So in this individual, Mr. J, there's a whole wide variety of things that may have led to acute tubular necrosis. Now, with chronic kidney disease, we say that there are fewer nephrons are functioning, and ultimately it's a decrease in GFR for more than 3 months. Now, what's interesting though is that we can see some remaining hypertrophy that's compensatory to a decrease in GFR. So if someone has kidney disease only in one and not both kidneys, it's possible then that the other kidney can get compensatory hypertrophy to attempt to restore normal GFR. So if you look here at the number of functioning nephrons and correlate that to glomerular filtration rate, we see that if you increase the number of functioning nephrons, you're going to have a higher GFR. And this is going to be a positive correlation here. Now it's nonlinear, where the number of functioning nephrons doesn't relate to GFR in a linear relationship. However, they do correlate pretty well, so that if you have a decrease in the number of nephrons, you're going to see a decrease in GFR. So what this means then is we can actually use GFR to assess how many functioning nephrons an individual may or may not have, and that gives us an idea of the extent of injury in their kidneys. So if their GFR is half of of normal, if normal is 125 mils per minute, and they have GFR that's half of that, that can indicate damage to nephrons that's extensive. So which of the following renal disorders is characterized by an increase in BUN and creatinine? Remember, these are both basically wastes that are normally eliminated by your kidneys. So which of these diseases would lead to the accumulation of waste in the blood? Would it be acute kidney disease, chronic kidney disease, or uremia? Only B and C, or all the above? Well, we know it's all the above, right? Because with any kind of form of damage to the kidneys that leads to a decrease in GFR, you're going to see an increase in the accumulation of nitrogenous waste within blood. So we're saying that if you measure someone's blood and their nitrogenous wastes are elevated, this indicates their kidneys are not functioning properly. Now, there are some other interesting sequelae of chronic kidney disease as well, and these all relate to normal functions of the kidneys. So long term, what can we see? What are some sequelae or side effects of chronic kidney disease or greater than 3 months? Well, for one, we're going to see electrolyte imbalances. So we see imbalances of things like sodium and potassium. Due to an accumulation of potassium, because your kidneys can't eliminate this, people can undergo hyperkalemia. And several chapters ago, we talked about how hyperkalemia increases resting membrane potentials of neurons and muscles throughout your body, which increases their excitability, so that you're going to be more likely to see action potentials and muscle contractions as a result. In fact, hyperkalemia can stop the heart because it stays in a contracted state. Now, sodium and water balance can also be disrupted, which can lead to things like hypertension, because normally the kidneys get rid of excess water and excess sodium, and if they can't eliminate these excesses, then that's going to lead to accumulation. So you're going to get fluid overload, which leads to hypertension. And then hypertension can put excess stress on your heart, which can lead to heart failure. We also learned that if you have fluid overload and an increase in vascular volume, that excess fluid can get forced into your body's tissues, leading to systemic edema. Now, we also see that via a decrease in the elimination of nitrogenous waste, it leads to what we call uremia. Now, uremia is just an accumulation of nitrogenous waste in the blood. So, first of all, nitrogenous wastes actually inhibit the coagulation cascade, and they interfere with proper coagulation. So what's kind of interesting here is that through the accumulation of nitrogenous waste, people can get bleeding disorders as a result. Uremia is also associated with pericarditis through inflammation, but other systemic effects can be things like sexual dysfunction, neurological manifestations, things like dementia. We have uremic dementia, which is an interesting sequela of chronic kidney disease, where people have a decrease in cognitive ability and normal reasoning from the accumulation of nitrogenous waste. There's different GI manifestations as well, where people get things like anorexia because they, those nitrogenous waste inhibit their drive to want to eat. We see skin disorders because when nitrogenous waste build up in your tissues, it can cause irritation and itching. So there's different rashes that are associated with uremia. And this also can impair proper immune function. So you can imagine then that there's a lot of interesting systemic effects from kidney disease. Now we know that the kidneys are also involved with producing erythropoietin. So if the kidneys are failing and they can't produce erythropoietin, that can lead to renal anemia, which is going to cause a decrease in, basically carrying capacity of oxygen in your blood. The kidneys are also involved with helping to eliminate acids and bases, or regulate pH. Now we know that acid is a byproduct of metabolism. So that if your kidneys can't get rid of excess acid, metabolic acids like lactic acid, phosphoric acid, different nitrogenous wastes, this can lead to acidosis. And acidosis actually has a negative effect on your bones by increasing bony breakdown. So you see this skeletal buffering here as well, and it causes ultimately osteodystrophies where the bone becomes more brittle as a result of the acidosis. Now, the kidneys also activate vitamin D3 into calcitriol, and we talked about how vitamin D is necessary for proper calcium absorption from your gut, and that if you're not absorbing enough calcium from your gut, then that can lead to hypocalcemia. Now, if the kidneys can't get rid of phosphate, then these phosphates can build up in your bloodstream. And what's fascinating here is that phosphates can scavenge calcium from the blood, and they cause what's called metastatic calcification, where essentially you get hydroxyapatite, or these calcium phosphate minerals that deposit in your body's tissues. Like we're saying that you can start to mineralize your body's tissues because phosphates take calcium out of solution, and that crystal precipitates in your body's tissues. Now, through the accumulation of phosphate, it's also going to increase your parathyroid glands to increase parathyroid hormone, and this hyperparathyroidism also increases bony breakdown, which can lead to a further osteodystrophy or brittling of bones. So just to summarize different disease manifestations of chronic kidney disease, we said that we had uremia or azotemia, which is an accumulation of nitrogenous waste like creatinine and bun. We said that this actually has central nervous system effects like dementia. It can actually cause GI disturbances and immunosuppression. We find altered fluid, electrolyte, and acid base is homeostasis as well. So we'll see things like salt wasting, acidosis, or even hyperkalemia. There's different cardiovascular complications because if you can't get rid of excess water, we see hypertension, and that can put excess stress on your heart, which actually leads to further heart disease. And these different GI disorders that can result can be things like anorexia, nausea, vomiting, or even ulcerations as well, because of a decrease in your immune system's ability to fight off bacteria. Bacteria can start to create ulcers within your gastric mucosa. So with the mineral metabolism disorders that result from chronic kidney disease, we said that we can see metastatic calcifications. This was a really interesting byproduct of hyperphosphatemia. If your kidneys can't get rid of excess phosphate, that excess phosphate in your bloodstream helps to precipitate calcium out of the blood. And that in itself causes hypocalcemia, because now what you're doing is instead of actually having calcium floating through the bloodstream, phosphate interacts with calcium, and that forms a crystal that precipitates out of blood into your body's tissues. Now, because of the hypocalcemia or low blood calcium here, because now the calcium is actually being mineralized into your tissues, that it increases parathyroid hormone production. And that parathyroid hormone increases calcium reabsorption from bone, which furthers bone loss and causes brittling of bone. But what's fascinating here is that if you're releasing more calcium from bone, that increases the production of these metastatic calcifications because, again, you're still going to have hyperphosphatemia, and when you take that calcium out of bone, now you're just going to put it back into your tissues by causing these metastatic calcifications. So what does that mean? Like what's being calcified? Well, a metastatic calcification would be mineralization of a connective tissue somewhere else in the body other than bone. So we're saying that like tendons and ligaments can get mineralized, the dermis can get mineralized, and you're going to find little aggregations of calcium phosphate minerals within tissues outside of bone. And this can be painful and limit joint movement. Now, because the kidneys also can't activate vitamin D if they're failing, you're actually going to see parathyroid hormone take over for this hypocalcemia, and that's also going to, ultimately increase the breakdown of bone and inhibition of osteoblasts. So you're also going to prevent bone from reforming. So other cardiovascular complications of chronic kidney disease would be things like anemia, and anemia can come from, basically the fact that you don't release erythropoietin from the kidneys. Now we know that your red blood cells don't last very long. They have an average lifespan of about 3 months. So if your kidneys are failing for 3 months, which is chronic kidney disease, then ultimately it can lead to anemia. Now you can see things like hemolysis and bone marrow suppression from the accumulation of nitrogenous wastes, and this is ultimately going to lead to things like weakness, fatigue, depression, insomnia, and decreasing cognitive function because of the fact that you can't supply your brain with enough oxygen to function properly. Now, because of a decrease in blood viscosity, you're going to see an increase in heart rate, as well as peripheral vasodilation to try to get blood to flow more readily. But what's interesting too is that because of the fact that your blood oxygen levels are low, it can lead to things like angina pectoris because of ischemia of the heart muscle. It can be painful, and due to bone marrow suppression, you can see bleeding disorders as well. Now we see a decrease in inflammation and immunity from chronic kidney disease, and this comes about from the fact that you're anemic and those nitrogenous wastes can inhibit cell division, so that the central and peripheral nervous systems become altered. You can see things like peripheral neuropathy, restless leg, as well as uremic encephalopathy, and this is essentially brain injury from nitrogenous wastes. Some sexual dysfunctions can also result from accumulation of nitrogenous waste, like hypofertility, dysmenorrhea, or even impotence. And skin disorders can result too from itching in the skin from those nitrogenous wastes. Due to a decrease in the production of sebum, you can see dryness or an increase in bruises because of the fact that you have bleeding disorder now, as well as terry nails. Now, if you look at a normal nail, it should normally have a lunule, right? And the lunule is that little white spot on the proximal end of the nail. Now, a terry nail suggests the accumulation of phosphate within the nail bed. And instead of the end of the nail looking more clear, it's just one white mass. And so you don't see a lunule because the whole nail is the color of a lunule. And so you can look at someone's nails as an indicator of kidney health, which is really interesting. Now, the scenario here says a man has chronic renal failure, has high creatinine in bun, is hyperkalemic and acidotic with normal PCO2, but also severe anemia. His blood glucose is 340 milligrams per deciliter 1 hour after a hospital meal, and he complains of having 2 broken toes recently, even though he eats a lot of dairy products. So the question here says, what's the most likely cause of his chronic kidney disease? What caused the anemia, and why are his bones brittle? So it sounds like he has some sugar dysfunction here, because we say that his blood sugar levels are elevated 1 hour after eating a meal. And because of this glucose intolerance, this indicates that he may be suffering from diabetes. Now, in a later chapter, we'll talk about how one of the sequelae of diabetes is cardiovascular disease. This is because blood sugar can damage proteins through glycosylation and cause blood vessels to get weaker. It can stimulate the accumulation of plaques within blood vessels. And so it's likely here that his chronic kidney disease is due to diabetes itself. Now, anemia would be a consequence or sequela of the kidney disease because of the fact that he's not releasing erythropoietin, so that's his renal anemia. And his bones would be more likely to be brittle because of the acidosis, and because of the fact that he has impaired vitamin D synthesis, that is, blood calcium levels are likely low, and even though he's eating dairy products, if his vitamin D levels are low, he's not going to be able to absorb that calcium from the food he's eating. So that chronic hypocalcemia leads to brittling of bones. So this question here says true or false? Chronic kidney disease leads to a decrease in cardiac output. And the answer is actually true, because if you can't get rid of excess fluid, it leads to hypertension, and you get corresponding hypoxemia from anemia. And both of these together, high blood pressure and low blood oxygen, really put a lot of stress on your heart. Like, it's going to increase myocardial workload. And so your heart has to work really hard to meet the metabolic demands of your body's tissues, and the heart muscle itself isn't receiving enough oxygen from the hypoxemia. And so your heart becomes unable to meet these metabolic demands, and due to heart failure itself, cardiac output will decrease. So to help someone with kidney disease, we have things like hemodialysis. And dialysis is essentially a mechanism we can use to replicate what the kidneys would normally do. And if you look here at this dialysis tube here, ultimately it's linked up with your blood flow, where you have arterial supply going into the dialysis tube and then venous supply going back into your bloodstream. And what we do then is we actually can pump fluids through this dialysis tubing, not in direct contact with the blood itself, but rather through these capillary tubes. And so you have dialysate that goes into the tubing, and then we have waste that leaves. And so what you're doing is you're essentially having the exchange of wastes from one fluid supply with another. So the fluid supply would be your dialysate, and that's going to interact with the dirty blood of the individual who has kidney disease. So if you can really zoom in on this capillary tubing here, what essentially is going to happen is that the dialysate is going to pull excess water out of this individual's blood. It's going to pull excess urea out of their blood, as well as excess potassium. And it's also going to increase bicarbonate absorption into their blood to help with the acidosis. And so all of this together helps to essentially remove wastes from their bloodstream and stabilize their blood pH through the absorption of bicarbonate, as well as remove excess water to keep their blood volume down. And individuals who have kidney disease may require dialysis every several days, and it ultimately just depends on the extent of their kidney disease. But this is an effective way to help get rid of wastes from someone's body. Now, this is an issue, though, in terms of infection risk, because what you're doing is you're pumping someone's blood through a foreign object. And these foreign objects, although they're sterilized pretty well, it's likely for bacteria to get in a variety of routes, so that individuals that are having dialysis are going to be at a higher risk for bacteremia, or bacteria in the blood. So there's another type of dialysis called peritoneal dialysis, and it's actually a much more simple method, where instead of relying on your kidney filtration membranes, you can actually rely on the peritoneum to filter the blood for you. So essentially what you can do is pump in a new solution into their peritoneum. So you're going to have an intraperitoneal catheter that delivers fluid to their peritoneal cavity. Now, with this fluid, essentially what happens is the exchange of nutrients and wastes with the blood and with the peritoneal fluid. And so what you can do then is actually drain that old peritoneal fluid into a waste bag, and then inject new peritoneal fluid back in. So what you're doing is you're relying on the peritoneum as an exchange of waste site rather than your kidneys. But what this also requires is a catheter that's placed into their peritoneal cavity. And because you have this little port here, again, these individuals are going to be at a higher risk of infection because they have a foreign object placed into their body.